In less than half a second, in the time it takes a camera to capture an image, you capture the most important moments of your life. In less than half a second, as fast as an eye blink, you could capture the most important moments of your patient's eye health. In less than half a second, you can get the whole picture. The OptiMap technology images the retina faster and with a wider field of view than ever. OptiMap technology produces images that reveal more pathology, helping you find disease sooner and treat it more effectively. Less than half a second can help you prevent vision loss in your patients, so those important moments never fade from view. Less than half a second, and this proven tool helps you uncover critical information to make more effective clinical decisions, as shown in over 400 peer-reviewed studies. Less than half a second, and you will see the value of OptiMap imaging and diagnosis, treatment planning, and patient engagement. Less than half a second can increase your practice economics. Faster retinal imaging frees you to do more patient-critical activity. The most important moments of your life can be captured in less than half a second. That includes an OptiMap image.
Welcome, everybody. Good evening. I bring you greetings from the team from Singapore, India, Korea, as well as the Nikon-Optos team in Japan. I'm Lee Shuyen, Head of Surgical Retina at the Singapore National Eye Centre and Clinical Director for the Retina Clinic at the Diabetic and Metabolism Centre at the Singapore General Hospital. Welcome to the Nikon-Optos webinar, Co-Operative Management of Diabetic Retinopathy, Diabetologists and Ophthalmologists hand in hand for the complications of this disease. Diabetic patients form a substantial percentage of our clinical practice, not only in the retina clinics, but also in the general and comprehensive ophthalmology clinics. It is important for us to understand their associated conditions and complications so that we can manage these patients better, and we should co-manage them with our friendly diabetologists. Joining me tonight are three eminent doctors from India and Korea. First, Dr. Samuel Satwik Rajapati is a diabetologist, and Dr. Raja Lakshmi is head of medical retina, and they are both from Mohan's Diabetes Specialties Center. They would be followed by myself and Dr. Lee Hong Woo from Konkuk University Medical Center in Korea. The first two speakers will go on first, and then we will have some time for question and answer. There will be some questions posed. I hope that you in the audience will be able to respond. If you have any burning questions, please type them into the chat board, and all of us will try to respond as quickly as possible. I hope you will enjoy the symposium. First up, we have Dr. Samuel, who will speak to us on the role of the diabetologist and endocrinologist in the care of patients with diabetic retinopathy.
A very good evening, everyone. It's truly an honor and privilege to be here with you all today. I bring greetings from Dr. Mohan's group of institutions, India. Today, I want to discuss about the role of an endocrinologist or a diabetologist in the care of patients with diabetic retinopathy. Before I actually jump into my topic, let me give you a brief introduction about diabetes as such, and also the pathophysiological aspects of diabetes. So diabetes is a multi-system disease, and which obviously needs a multidisciplinary care. Let's not forget that it's predominantly a vascular disease. The hyperglycemia-mediated tissue damage is because of the repeated acute changes in the cellular metabolism and also the cumulative long-term changes in the macromolecules. But what influences the extent of the damage is the genetic susceptibility, but also independent accelerating factors like hypertension and hyperlipidemia. So this is an overview of the complication of diabetes. The acute and the non-classical are beyond the scope of this talk. I would like to dwell on the chronic complications, especially the microvascular complications, which include the retinopathy, nephropathy, and neuropathy. But have you ever wondered why is there a selective damage to few cells when the whole almost all cells are backed with this excess blood glucose? Especially the cells that do take the major hit are the capillary endothelial cells of the retina, the mesangial cells in glomerulus, and also the Schwann cells in the peripheral nerves. But why do they take the major hit? It's because of their inability to regulate their internal glucose concentration, in contrast to those other cells which can regulate. That's why the damage is predominantly more here in these cells. How does hypoglycemia cause complications? Different pathways, but the predominant ones are the aldose reductase pathway, where excess glucose is converted into sorbitol, an osmotic molecule, causes trapped intracellularly, causing cellular edema. That's one of the reasons for cataracts in the lens also. The second thing is a free radical production and oxidative damage. And the third one is the accumulation of something called as AGEs, which are advanced glycation end products. So these are nothing but the combination of sugar and protein, which are actually toxic to the retina. At the core, diabetic retinopathy is nothing but a microangiopathy leading to ischemia and the release of things like VEGF, which is, of course, a therapeutic target in the treatment of diabetic retinopathy. So what is the role of an endocrinologist here? I'm going to talk about 6 different roles and share our little experience and close. The first role is to screen and diagnose diabetes early. Diabetes is such a global problem. We are looking at 537 million adults. This is the latest stats by the IDF released in 2021. What is more interesting and worrying is the huge number of rise in the pre-diabetic cases who have potential to become diabetics. And in the South Asia, the numbers are staggering. 90 million and predicted rises 152 million by 2045. So I don't think that it's just the job of an endocrinologist, but all of the community healthcare workers, almost every doctor, primary care physicians, we all need to work in shortening the delay in the diagnosis of diabetes, because it gives us more scope for us to address therapeutically to alter the risk factors that lead to complications. This wonderful paper by Olofs de Teer showed that early detection of type 2 diabetes combined with screening for diabetic retinopathy reduce the prevalence and severity of retinopathy. That's a point number 1. Whom to screen? I would say everyone, but area recommends that those who have risk factors and those who don't have risk factors. Those who have risk factors like obesity and multiple family history and other risk factors definitely need a more frequent screening compared to those who don't. There's the simple tool called IDRS risk score, which is developed by our chairman, Dr. Mohan, which includes age, waist circumference, physical activity, and family history of diabetes. If you score high on this calculator, then you need screening definitely for sure. The fasting, the 2-hour values in the A1C are the diagnostic criteria which we use to screen for diabetes. The second role is to screen for complications. I would say it's surprising there are many patients who have diabetes for years, but have never been screened for both the microvascular and the macrovascular complications. Why screen? Because most patients are asymptomatic. Take retinopathy, for example. Most of you could experience that. Many patients don't even feel any symptoms. So unless until you do a dilated retinal exam. So if the patient is a type 1 diabetes, you can wait until 5 years to screen. If it is type 2 diabetes, the guidelines recommend that you screen at the time of diagnosis. Of course, there are special situations like pregnancy, where it has a strong relation to diabetic retinopathy, where there is known to be worsening. We need to screen in these special situations. So how do you know if there is an ongoing vascular damage? The earliest sign of a vascular damage is a simple test called microalbuminuria. That is the second role, is to screen for complications. The third one is tight glycemic control and treating to the target. I cannot emphasize on treating the patients to our target. I think this is the role of every endocrinologist and diabetologist to treat the HbA1c, treat the sugar to control. The recommended HbA1c by ADA is around 7, but there is enough amount of data that is already there, and it's gets strong day by day, that intensive glycemic control and treating early translate into reduced risk of microvascular complications. Predominantly, we're getting this data from type 1s from a study called DCCT and a follow-up study called EDIC. And type 2 diabetes, there is this landmark trial called the UK-PDS trial. So if you look at this graph here, there's the DCCT study where the intensive therapy group had a 76% reduction in retinopathy. I think that's wonderful. So if you start treating early, then what they've found is the cells remember that good control, and they remember what is called as metabolic memory. Even after certain age, after certain duration, when the control is slightly off, the cells do remember, and the chance of complications are less. So the UK-PDS data also confirms the same thing, which was done in type 2 diabetic patients. There was a decreased need for retinal photocoagulation in the intensive treatment group compared to the conventional group. And even the 6-year of follow-up study with UK-PDS has showed that the intensive group showed reduced worsening of diabetic retinopathy. The accordion eye study also demonstrated that intensive glycemic control confers protection. So there is no doubt, again and again, various studies that we need intensive glycemic control. We need to hit hard and hit early to prevent complications. So there's another aspect that's coming up a lot these days is the glycemic variability. We had only talked about the HbA1c, but how the sugars are fluctuating all throughout the day, the inter-day and the intraday variability is very, very important also to reduce complications. So there are wonderful tools like CGM devices which can track the blood sugar levels all throughout the day. There is growing evidence that in type 2 diabetic patients, that more the variability, more the chance of complications, more retinopathy and more progression of diabetic retinopathy, more people needing a laser treatment and also further treatment approaches. So even in type 1 diabetes, we need more data, but this study by Hayatala et al. Has showed that more variability is associated with an increased risk of retinopathy requiring a laser treatment. So the next role is to address metabolic control. I would say systemic medical management is very crucial in successful outcomes. So there are modifiable risk factors for diabetic retinopathy and non-modifiable ones. Addressing glucose, addressing blood pressure. Blood pressure, for example, is an independent risk factor for diabetic retinopathy. Addressing lipids, anemia, smoking, and also treating comorbid conditions like nephropathy, cardiovascular disease. All of these are very, very important in improving outcomes. So there are certain group of diabetic medications which can actually aggravate diabetic macular edema. So we need to tweak the medications, look carefully at the prescriptions which can cause probably worsening. Regarding dyslipidemia, we know the popular field study where fenofibrate showed the benefit in reducing the retinopathy progression and need for laser treatment in those with pre-existing retinopathy, and also a cord eye study where intense glycemic control was used along with the combination of statins. So what I'm trying to emphasize is that not glycemia is important, but we also need to follow a multifactorial approach to actually improve the outcomes. Yes. The other role, we are blessed with a good team of doctors here at our centers. I think globally, the outcomes can be improved when you collaborate properly with our doctors. I think there's a need. Diabetes needs different specialty, the help of different specialties. It is a multidisciplinary care. So we need to take help and inputs from all of the specialists. So generally here in our center, we get calls for fitness for FFA, intravitreal injections and surgical procedures. But I would say this paper, the Swedish paper, but again, Alopsa Deter showed showed reduction in blindness, which was clearly attributed to a good collaborative management between the general practitioners, diabetologists and ophthalmologists. So collaboration is the key, I would say, for improving the outcomes. Lastly, I would like to share our experience with telediabetology. So in this day and age, harnessing the power of technology is very, very important because many people are getting tech savvy and a lot of devices there. Many people, the generations, the times have changed. So Dr. Mohan Diabetes Specialty Center, which is a tertiary care center, a chain of diabetic care hospitals, we have around 50 branches in India. Even before the COVID hit, we tried this experiment, I would say this model to reach out the rural population. This is the popularly called the Chunampet model for rural diabetes care, where we picked up a village in the south of India, near to Chennai, and we use the tele-diabetology approach. So all the concept here is there was a tele-diabetology man which used to go there to that village. It was a mass screening campaign that was done, and it was well equipped with facilities like retinal camera, the Doppler, biothessiometry, and the photographs, the foot photographs, the ECGs, all of them were sent to the consultant who is sitting at our main center. And we used to pick up high-risk cases and advanced cases, and understand that for the rural people to come and travel all the way to spend a lot of money, they're not affordable, and it's very, very difficult. And this tele-diabetology actually has bridged the gap, and I would say they have saved many lives and saved many eyes and many feet. So this was well applauded, well received by both the national and international media. So COVID actually, we had to shift gears with COVID, because this was even the rural tele-diabetology concept was even pre-COVID, but COVID actually increased our acceptance of telemedicine. This was the model we used, where the call lands up at the call center, from the patient lands up at the call center. Then it is connected to the dietitian. Dietitian reviews the reports, advises the test to be done, and the phlebotomist goes to the patient doorstep and collects the sample. Reports are generated, and consultant views the reports, thus through a teleconsultation platform, both audio and video. Prescription is generated, and the medicines are delivered at the doorstep. The patient, without moving from his house, was getting high quality diabetes care. I think this is something which everyone needs to adopt in the coming days, because there's an expanding role for mobile platforms. We have retinal photographs that are coming in. So for the eye, there is blood pressure monitors, there is CGMs, there the lab values. All of them can be integrated, and we have to use the power of technology to improve patient care. So to summarize, the roles are early screening and diagnosis, treating to the target, meticulous monitoring, follow-up, metabolic control, systemic medical management, inter-referral specialist care, and using the power of technology through tele-diabetology to bridge this gap, both improving patient care in the rural and urban setups. So thank you very much for this, for your patient listening.
Good evening to you all. At the outset, I wish to thank Nikon for organizing such an excellent webinar. Today, I'll be speaking to you about effective screening for diabetic retinopathy at a diabetes care center, a collaborative effort of a diabetologist and an ophthalmologist in managing diabetic retinopathy. I have no conflicts of interest or financial disclosures. As you're all aware, diabetic retinopathy is a specific microvascular ocular complication of diabetes that can occur both in type 1 and type 2 diabetes due to prolonged uncontrolled hyperglycemia, and it is one of the most important causes of preventable blindness. Patients with diabetes very often have a long asymptomatic phase where they may have no retinopathy or mild or moderate non-proliferative diabetic retinopathy with normal vision and no eye complaints, until after a long asymptomatic phase, they may progress to sight-threatening diabetic retinopathy, which could be presence of severe NPDR or diabetic macular edema involving the central vision area of retina, or development of proliferative diabetic retinopathy with fibrous proliferance and dense vitreous hemorrhage. It's important to screen the patients early before they progress to advanced diabetic eye disease and treat them early. Let's understand the global burden of diabetes and diabetic retinopathy. Diabetic retinopathy respects the rule of 1/3. Among the people with diabetes, 1/3 of them have diabetic retinopathy, and 1/3 of those with diabetic retinopathy have sight-threatening diabetic retinopathy. You can see that the same projections are shown for the year 2040 also, and where about 70 million people are expected to have vision-threatening diabetic retinopathy by the year 2040, which is a huge burden. Let's understand the burden of diabetic retinopathy in Asia. Over 60% of individuals with diabetes live in Asia, and the prevalence of diabetes in Southeast Asia is estimated to be about 90 million, and 20% of people with diabetes have retinopathy is the estimated prevalence of retinopathy. That is, almost every 5th person with diabetes in Asia can have diabetic retinopathy. How do we screen people for retinopathy to prevent vision loss? The diabetologists or the physicians can refer the patients to the ophthalmologist for fundus examination by indirect ophthalmoscopy. If the endocrinology clinics have desktop conventional cameras, fundus photographs can be taken, and the photographs can be shared with the ophthalmologist for grading of the retinopathy. Smaller diabetes clinics have smartphone-based fundus cameras or low-cost fundus cameras. These cameras can be connected through a telemedicine network, and the retinal images can be transmitted through the LAN network for to the centralized grading center for grading of the retinal images by the retina specialists or the trained graders. So annual retinal assessment is recommended for all people with diabetes, but the point of care for people with diabetes will be the physicians, and they may not consult the ophthalmologist, as majority of them would be asymptomatic. So it is essential that the patients who come to the physicians are screened for diabetic retinopathy. Fundus photography has been accepted as a standard for DR screening, and very often in low and middle income countries like India, screening for retinopathy has become more opportunistic, and it is not systematic the way it is in countries like UK. So, and teleophthalmology based retinal screening has also started getting accepted as a viable option. We at Dr. Mohan's Diabetes Center, we validated a smartphone-based fundus camera, which can be used in handheld mode, or it can be fixed to a table and used for fundus imaging. We validated it against the conventional desktop camera, and this camera is easy to use with minimal training, and it has a unique feature that the patient's photographs get stored in separate folders. And this, it also has an artificial intelligence enabled platform, and it is quite useful to screen for any grade of diabetic retinopathy in day-to-day practice. And we have these cameras at our diabetes care centers. We have also used these handheld Visuscout cameras for screening in camps, where these handheld cameras can be used to take images of the posterior pole, and it can be used in the field, etc. Of course, we have the ultra wide field imaging with the Optos Diabetic Plus camera. It gives the big picture of diabetic retinopathy, providing a 200-degree field of view of the fundus, and it helps us to visualize the peripheral retinal lesions. You can see the smaller grid where the ETDRS just shows the posterior pole, whereas the Optos Diabetic Plus helps us view the periphery. Increased number of peripheral lesions increases the risk for progression to PDR. So ultra-wide field imaging definitely will change the way people look at diabetic retinopathy. So how would people in rural areas or remote areas have access to specialized diabetes care or specialized eye care? We have a fully equipped telemedicine van which goes around villages at Chunambed. All investigations can be performed inside this van: HbA1c, blood pressure, the fundus photography, ECG, biospeciometry, all of this can be performed. And the diabetologists and the ophthalmologists, they provide consultation to the patient through video conferencing. And this is a very valuable tool for patients who don't have access to direct specialized care. So we have in our diabetes care clinics, some clinics have the ophthalmologists who do the fundus examination. Some clinics have fundus cameras where photographs are taken by the trained technicians. In both these modes, we find that almost more than one third of them have diabetic retinopathy detected. In just one single calendar year, we have had more than 59,000 patients who have been screened for diabetic retinopathy, sight-threatening diabetic retinopathy being detected in over 10% of the patients. So this is quite a valuable way of screening patients for diabetic retinopathy across India at various diabetes care clinics of Dr. Mohan's Diabetes. So what is the basic difference between ophthalmoscopy and telemedicine? Ophthalmoscopy is performed by the ophthalmologist or a trained retina specialist. Retinal photographs are taken by trained photographers or technicians with good quality fundus camera. Of course, there is a cost to the fundus camera, but the cost to the patient is less. It is more convenient to the patient because it's less travel, less time spent, and especially during the pandemic and lockdown, telemedicine and teleophthalmology have been a boon to patients. All patients with diabetes need to be screened annually. And basically, there are over 90 million people with diabetes to be screened annually in Southeast Asia. Ophthalmologists being involved in this is not feasible. So an automated approach for detection of retinopathy is going to be very useful to tackle this burden. So artificial intelligence would be the main solution. Let me show you how we use artificial intelligence real time. This is a patient who visited one of our branches where fundus photographs were taken for the patient who was asymptomatic with just 3 years of diabetes. You can see large fronts of new vessels seen at the posterior pole in the right eye and diabetic macular edema in the left eye. Images were sent to the ophthalmologist for grading through the telemedicine network. At the same time, the images were uploaded into the AI platform. The AI gave the right diagnosis of proliferative diabetic retinopathy and clinically significant macular edema. So the diabetologist had the diagnosis with him even before the ophthalmologist could send him the diagnosis. The asymptomatic patient was immediately referred by the diabetologist to the ophthalmologist for FFA, OCT, and PRP laser treatment. And this was possible thanks to AI and teleophthalmology. This use of AI real time was possible after we did a study at Dr. Mohan's center using IART AI and smartphone-based fundus images. We did a study and we found that IART AI has showed a very high sensitivity using remedio fundus on phone images. Both the sensitivity and specificity were very good, and AI could help detect diabetic retinopathy accurately, sight-threatening DR, referable DR with high sensitivity and specificity. And early detection of sight-threatening retinopathy is very helpful as it can help in timely referral to the retina specialist. But what are the limitations of use of such AI? The machine may miss if unless it is trained to identify a particular problem. For instance, it cannot identify, if it is trained only to identify retinopathy, it can't detect other eye problems in the retina. And suppose the images are not very clear due to cataract or other media opacities, the AI may not be able to detect retinopathy if the image quality is not good. So there is always a fear now with everybody speaking about AI, if it will replace ophthalmologists in I don't think that fear is needed. It cannot replace the role of ophthalmologists. In fact, there'll be more number of people with sight-threatening retinopathy who will be detected, and they will have to meet the ophthalmologist or the retina specialist for further management. AI can definitely ease the pressure on the healthcare systems, especially in countries like India, where the resources for diabetic retinopathy screening are not sufficient. So what are the steps to reduce the diabetic retinopathy burden? This is through teamwork involving the endocrinologist, the ophthalmologist, the diabetes educator, as well as the patient. Emphasizing on lifestyle modification, making use of teleophthalmology for diabetic retinopathy screening, using automated detection of DR and artificial intelligence will definitely play a long role in detecting diabetic retinopathy early and helping in timely management. So I wish to conclude by saying that over 1/3 of the individuals with diabetes visiting the diabetes care centers had retinopathy. So teleophthalmology in these diabetes clinics is very useful for timely DR detection. Only 10% of them had sight-threatening retinopathy requiring referral to the retina specialist. This screening is through teamwork. It is an excellent model as holistic screening for all complications of diabetes is possible. Innovative technology like smartphone, teleophthalmology, use of artificial intelligence are valuable strategies to improve DR screening in diabetes clinics, especially during the pandemic times. Thank you. Thanks for your attention. This is our team. Thank you.
Thank you very much for the two very extensive and enlightening lectures. Do you have any questions? Please feel free to type them into the chat. Otherwise, we are going to pose some questions to all of you in the audience. So let me just start off first. What country, okay, the first panelist, first set of questions we have would be, from which country are you participating from, joining us from? We have a whole bunch of 300 plus participants who have registered from all these countries. So do let us know where you are from. I think it's quite interesting that it is a good mix of more developed countries and countries that have areas of challenges in terms of coverage, like what Dr. Raja Lakshmi told us, that the more rural areas of India, probably in Indonesia and Thailand, we have to find other means to get to these patients in a timely manner. Thank you for all your responses. We have an interesting mix. Our next question, please. So many places have national as well as regional screening programs, like was mentioned by our two previous speakers in the UK, as well as in Singapore. We have a national diabetic retinopathy screening program. I think that helps a lot with trying to drive down the rates of complications or in terms of diabetic retinopathy and providing access. Dr. Lee, do you have that in Korea?
No, we don't have a national-wide program for diabetic retinopathy screening, but annually we do some diabetic retinopathy screening in some several population, not all for all.
And so, Dr. Raja Lakshmi, how do you manage to cover as extensively as possible in terms of your, cities as well as the more rural villages to try to curtail the problems?
Here, I think the mode will be, as I rightly said, as mentioned in my talk, it will be for the patients, the diabetologists have to tell patients regarding the importance of having the regular examination done. It would definitely work by interreferral between the diabetologist and the ophthalmologist. Some regular, to increase the awareness among the patients, definitely some education materials, putting up some posters in the various patient waiting areas. So to sensitize patients, patients are aware about cataract, patients are aware to a fair extent about glaucoma, but patients do not know that the retina can get affected due to diabetes. They know about their kidneys, they know about the foot, but about the eyes, they don't know much about the retina. If we can have ways to increase the awareness among patients, then they will. Then it will be easier to for the patients to go and meet the ophthalmologist, either have a photograph taken. In fact, it should be a system like where they just go and stand on a weighing machine and they know their weight. Similarly, if there's going to be a system where they can just go take a photograph and they'll know whether they are going to have retinopathy or not, that should be the future that we look forward to, where every patient gets screened for retinopathy.
Dr. Samuel, do you face patients who are resistant to having, going for an eye checkup because they might say, oh, it's going to cost me money, or I don't have time, I can't make it because of work?
Absolutely, yes. It's such a great challenge to actually convince patients because most of them are asymptomatic. So it's kind of, we need a double emphasis. We need to explain to them because when they don't have symptoms, when they don't have issues with the vision, most of the time they cross-check, and especially in India, I don't know how it is there. Many people confuse the retinal exam with the refraction. So they just said, we got my eye checked up recently. So we need to actually have to push the patients to get that done. Of course, people who do have symptoms it's easy to convince them, but large chunk of patients we generally see don't have symptoms. So it's quite a bit, it's a challenging thing here.
Yeah, and once they have symptoms, it's usually not a good sign already.
Exactly.
Okay, that's, do we have any more time, or are we moving on to the next section?
We have a question where
yes,
the person has asked if any lesion on an ultra-wide field camera, which was not found in handheld camera. Yes, the ultra-wide field camera can pick up a lot of peripheral lesions. Sometimes
the posterior pole, which can get picked up, may be totally silent, and a patient can have peripheral lesions. That is the advantage of ultra wide field imaging, where more peripheral lesions can be picked up with the posterior pole not having any lesions also. Definitely, it is going to change the way where people do screening and grading, and it could soon become the gold standard for retinopathy screening.
Yes, I totally agree. I think we're all actually appreciating more and more the value of wide-angle imaging systems. We can see things that we previously were not able to, and you actually grade the patients at a higher level than if you had just used the standard methods of screening.
True.
Okay, I think we are going to move on to the next set of talks.
I am Li Shuyan from the Singapore National Eye Centre. I would like to thank Nikon and Optos for inviting me to participate in this webinar. Now I would like to share with you our experiences using the ultra-wide field imaging for diabetic retinopathy, screening, grading, and treatment. Microvascular changes in diabetic retinopathy is significant. Through technological advancements in imaging, we have greatly increased our understanding of the underlying cause of diabetic retinopathy, how structural changes to the retinal capillaries result in microaneurysmal changes, fluid extravasation, and lipid exudation. With the evolution of fundus fluorescein angiography, we were able to further understand retinal ischemia and peripheral non-perfusion, plus the breakdown of blood-retinal barrier in advanced cases. This highlighted the importance of the ability to assess the peripheral retina and also highlighted the impact of neovascularization and vascular endothelial growth factor. The landmark trials of diabetic retinopathy study, the DRS, early treatment diabetic retinopathy study, the ETDRS, diabetes control and complications trial, the DCCT, and many others have shown us that it is of great importance that diabetics have eye reviews, particularly of their retina, regularly. The aim of screening is to be able to detect referable cases for timely, full ophthalmic examination so that treatment can be instituted early to prevent permanent loss of vision. Screening requires a high sensitivity and must have coordinated access to ophthalmologists. These trials have used as the gold standard 35mm 7-field stereo images, which will then enable us to grade retinopathy in mild, moderate, or severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy in the periphery. And the maculas are assessed to be initially clinically or non-clinically significant macular edema, and now we label them as center involving or non-center involving diabetic macular edema. Revolutionary change recently have enabled us to move from single field 45-degree images for 7-field ETDRS imaging to a single image wide field of 100 degrees or ultra wide field of 200 degrees imaging. This has allowed the retinal surface to be evaluated from 34% to about 80%, allowing us better assessment of the peripheral retina. These are fundus images from the same eye, and you can see how the single image on the left only shows the image of the posterior pole, whereas the wide field image on the right shows the entire retina almost aura to aura. The Optos SLO is able to provide this. Several authors, including Neubauer, have shown that the ultra-wide field compared to fundoscopy has 94% sensitivity and 100% specificity to detect more than a grade of mild non-proliferative diabetic retinopathy. Several authors have shown that the there is great benefit in using ultra-wide field for diabetic retinopathy grading. In 2019, ILO's group published in AJO that there was moderate to substantial agreement between 7-field ETDRS and ultra-wide field for grading, and predominantly peripheral lesions were more easily detected. This can result in the severity grading by greater than 2 in 11% of eyes, and the frequency of diabetic retinopathy detection could increase by nearly 2 times. Many other authors have also shown that diabetic changes can occur in up to 40% in areas beyond that covered by the 7 fields detected, and therefore making the grading of the diabetic retinopathy a higher level in up to 15%. We know that fluorescein angiography is the only modality to show leakage. It enables us to understand capillary non-perfusion and assesses the foveal avascular zone well. However, now OCTA is being increasingly used, although there are certain limitations there. We know that non-perfusion is usually in the periphery until the mid-periphery, except in very severe cases. And Shimizu has previously shown that in both proliferative diabetic retinopathy as well as central vein occlusions, there's greater peripheral non-perfusion is associated with neovascularization at the disc and in the retina. Conventional angiography would only cover 45 to 60 degrees of field in one exposure, and the peripheral fields would need to be acquired with the patients redirecting their gaze, hopefully with a dilated pupil. However, there is still image distortion and the far periphery cannot be assessed adequately. Lenses can be added on to the imaging system to increase the view, but this can be technically challenging and an experienced imaging specialist would be required. And you can see that the ultra-wide field can increase the area of view significantly compared to the conventional camera. So like in age-related macular degeneration evaluation, diabetic eyes now can undergo multimodal imaging for better understanding of the disease, both at baseline as well as for follow-up, particularly as a response to therapy. You can see that in this eye, we perform the ultra-wide field to show the area of macular edema, and that can be seen on the optical coherence tomography as well as fundus fluorescein angiography. Nowadays, it is quite common for us to combine this assessment with optical coherence tomography and its OCTA. And you can see in this eye, the images on top on the right side shows the areas of OCTA showing non-perfusion or capillary dropout in the superficial as well as deep plexus associated with significant cystic changes at the fovea. And with treatment, we can see that the retinal thickness has significantly returned to normal. However, there are still areas of capillary non-perfusion within the macula. So ultra-wide field fluorescein angiography in proliferative diabetic retinopathy, as you can see in the image that I quote from Liu and Arevalo, you are able to see the peripheral retinal changes much more easily. We can detect more NVEs compared to the 7 field. And you can see that in different reports, at least 10 or more % of PDRIs had NVEs outside the 7 field area. Ultra-wide field fluorescein angiography is also good for prognostication. The predominantly peripheral lesions outside ETDRS fields have been shown to increase the risk of DR progression over 4 years by at least 3 times, and the development of proliferative disease over 4 years by 4.7 times. And the peripheral non-perfusion on ultra-wide field FA is associated with increased risks of NVEs and macular ischemia. Some authors have even attempted to measure and calculate the extent of ischemia and leakage, as well as measure the size of the FAZ for visual prognostication. One major advantage of ultra-wide field FA is to enable targeted PRP. In the traditional sense, pan-retinal photocoagulation is a blunderbuss laser treatment of the entire 360 retina, but with fluorescein guided laser, we are able to reduce the extent of laser coverage, reduce the amount of total laser power so that there's preservation of the healthy retina, and an attempt to reduce the potential complications of traditional PRP, such as visual field constriction, progression of macular edema, reduced color sensitivity, reduced night vision, and contrast. It has also been shown to be still effective in the regression of new vessels. Let me share some case illustrations. This man presented with more than 10 years of diabetes with persistently high HbA1c levels. He was initially diagnosed with diabetic macular edema, but refused treatment initially, and then he, after that, allowed for some sporadic anti-VEGF treatment. Over the course of 2 years, he progressed from mild to proliferative diabetic retinopathy, for which PRP was started. And you can see in this fundus photo, before PRP was started, the right eye was fairly quiet looking on the ultra-wide field image. On the left, you can see an area of pre-retinal hemorrhage. Fluorescein angiography shows significant activity, on the other hand, with non-perfusion and neovascularization. So PRP was started on this patient, and you can see that we did it with fluorescein guidance and therefore not as extensively as we traditionally would have. This is another patient also with a poorly controlled diabetic status. The right eye, you can see there's significant macular edema, and the OCT shows neurosensory detachment with retinal thickening. The left eye is more severely impacted, also with macular edema and significant hemorrhages all around, particularly around the posterior pole. Fluorescein angiography shows that there is significant capillary non-perfusion in the macula as well as in the periphery with extensive leakage. And the same thing is seen on the left with a much more extensive leak. So the patient was started on bilateral intravitreal bevacizumab as well as focal lasers, and over the course of a year, the vision gradually improved as the macula slowly started to dry. However, after the PRP, he returned and was shown to have floaters and account fingers vision. He had progressed to proliferative disease, and there was left vitreous hemorrhage with a pre-retinal fibrovascular proliferation and subhyaloid hemorrhage. You can see on the OCT in the left eye that there is blood trapped underneath the posterior hyaloid. So this patient had to undergo transpars planar vitrectomy, and throughout this surgery there's quite a lot of hemorrhage that needed to be controlled with hemostasis. There was adherent posterior hyaloid as well as fibrovascular membranes on the retinal surface that needed to be slowly dissected off the surface of the retina, and you can see that slowly the blood is cleared and the view is improved. The traction is gradually relieved, and at the end of the surgery, the macula does not look too bad. This other patient is a 75-year-old lady with persistently high sugars and no prior eye screen. She presented with a persistent right inferior visual field defect. The vision was 624 and 69 for the right and left eyes respectively. You can see that the patient has significant bilateral asteroid hyalosis. I had great difficulty in assessing the grade of the diabetic retinopathy, but when I managed to peep at the optic nerve on the right side through the asteroid hyalosis, I thought that I saw some new vessels at the disc. Fluorescein angiography is an excellent tool to be able to understand the retina better in the presence of dense asteroid hyalosis, like in this case. You will see that there is significant non-perfusion, particularly in the superior as well as temporal areas of this eye. There's significant vascular pruning. There are also new vessels seen along the inferior arcade as well as nasally. In the left eye, not as bad, but there was also significant new vessels seen in the nasal as well as other parts of the retina. We can see that in her fovea, there's significant enlargement of the FAZ, and this is in agreement with what we see on the optical coherence tomogram angiography for the superficial and deep plexus on the right side. The left eye has a much healthier FAZ. So, and then this is another patient, a young diabetic with greater than 10 years of diabetes on oral as well as insulin therapy. She presented with right eye blurring of vision of 1 month, and you can see that her vision was 660 and 69, and there was a relative afferent pupillary defect on the right side. She had bilateral PDR and started on PRP for both eyes. The right eye then progressed, and we performed a pars plana vitrectomy to relieve the vitreomacular traction. This is her post-op picture. The macula looks much better compared to pre-op, and the vision was still improving. Unfortunately, the left eye has decided to crunch, and she has been scheduled for left vitrectomy. This is another patient who is 37 and also of bad control initially, with a more recent increase in control, but that spurred a progression from severe non-proliferative diabetic retinopathy to proliferative. And you can see how extensively the non-perfusion is with neovascularization. The managing team decided to start with monthly intravitreal bevacizumab without laser treatment. However, after 10 months, she developed vitreous hemorrhage, and so laser treatment was started with continued intravitreal bilateral bevacizumab. Despite all that, 6 months later, the vision deteriorated further, and left pars plana vitrectomy was done to clear the vitreous hemorrhage. There was a localized inferinasal tractional retinal detachment and large areas of untreated retina temporally. All that was treated, and she managed to achieve a post-op vision of 6.9. So I hope this highlights the importance of how ultra-wide field can be a significant tool in your clinical practice to assess, manage, follow up, as well as prognosticate patients with diabetic retinopathy. Thank you very much.
Good evening. My name is Hyung Lee from Konkuk University Medical Center in Korea. It's a great honor to present in this wonderful webinar. Today, my talk will be about the surgical role of ultra-wide-field imaging in diabetic retinopathy. Recent research has begun to highlight the role of peripheral pathology in early detection of diabetic retinopathy. Also, prior studies has demonstrated the importance of utilizing ultra-wide-field imaging to visualize the periphery. In preoperative period, the ultra-wide-field fundus photo can inform us of pathologic changes even in the peripheral area in a single image. When this ultra-wide-field photo is combined with ultra-wide-field fluorescein angiography, we can predict the main surgical area and potential adhesive area of bleeding or iatrogenic tears. Here's the major indication of diabetic vitrectomy: non-clearing vitreous hemorrhage, progressive fibrovascular proliferation, and TRD threatening the macula, or TRD accompanying RRD. So I'll explain how the ultra-wide-field imaging helps to set a surgical plan for each indication. Here's a case of a middle-aged male whose vision is at the finger count level. The patient had pre-retinal and vitreous hemorrhage, and this was not cleared even after the intravitreal bevacizumab injection. The OCT image at the right side represents the hemorrhages located at the posterior surface of hyaloid and macular edema. As you can see, we could find calm periphery without significant traction. It was not an urgent case, but the patient wanted fast relief of visual disturbance, so we planned 25-gauge vitrectomy. There was no unexpected events, and you can see flat retina at POD 10 and 60. Visual acuity was also improved. Macular edema was also improved. Now, let's move on to the case of progressively increasing fibrous membrane. A 30-year-old female had a vision loss as 2060. At her initial visit, preretinal and vitreous hemorrhages were observed mainly at the inferior side, and ultra-wide-field angiography images shows the multiple neovascularization at the mid-periphery. These two wide-field images give information about the whole landscape of retina. The patient can also benefit by understanding her status at a glance. Unfortunately, her diabetic control was not stable, and the fibrovascular proliferation still progressed at the vascular arcade even after the PRP. However, the peripheral PRP area was stable, indicating that the surgery might not be complex. In the post-op period, but we found a new PVR change very well depicted in the left ultra-wide-field image. This PVR change was getting denser and started to make a traction, so we removed this PVR and stabilized her retina. Let's see the case of macular traction. In ultra-wide-field image, dense fibrous membrane with traction is mainly located at optic disc and its superior area. Ultra-wide-field image usually shows horizontal areas better than the superior and inferior areas. In this case, we wanted to convince that there is no other tractional change other than the central area. Then we let the patient simply look up and down for additional images. Then we could convince that the fibrous membrane was not extended to the superior and inferior periphery. Since the macular traction was obvious, we planned vitrectomy. After the surgery, the fibrous membrane was removed from the expected area, as in the preoperative ultra-wide-field image. And also the macular traction was resolved. And the next case also shows the advantage of ultra-wide-field imaging in the peripheral problem. His diabetic retinopathy was mild at first, and also visual acuity was good. But poor glycemic control induced a vitreous hemorrhage. In ultra-wide-field image, as you can see in the left side, the tractional detachment occurred at nasal periphery. With the ultra-wide-field imaging, we cannot miss this kind of important change. Then the early vitrectomy successfully stabilized the detached retina. Here's a final case with severe TRD. A 30-year-old female with finger count vision in the right eye visited our clinic. Thick fibrous membrane spans horizontally with the defects and detachment at nasal periphery. So we plan to release the traction at the nasal side and remove the membrane on the posterior pole also. Okay, let's see the movie in this case. At the nasal side, we conducted peripheral retinectomy first and tried to find a cleft between the membrane and retina. Pick did not work, so we used horizontal scissors to make a space as much as possible. Then PFCL flattened the detached retina and also made more space between the membrane and the retina. Using vitrectomy probe, we removed this membrane further to the nasal side. Then photocoagulation was done, and then finally the membrane at the posterior pole was peeled off as planned from ultra-wide-field image. Additional photocoagulation was done for iatrogenic tear, and silicone oil was injected. To sum up, in preoperative period, I think that ultra-wide-field imaging helps surgeons be prepared. Based on the integrative information from central and peripheral area, surgeon can think about proper sequence of operation and proper instruments, and also be reminded of potential risks. All this makes surgeons less annoyed and successfully carry out operation, even in complex cases. We can easily follow up the post-operative situation because it just takes about 30 seconds when taken ultra-wide field imaging. This also makes patients more comfortable. Now, let me point out some of the considerations to successfully conduct a diabetic vitrectomy. These are not directly associated with the wide field imaging, but let me take this opportunity to discuss about some surgical issues we can think about in diabetic retinopathy. First, the preoperative bevacizumab. As you all know, bevacizumab lowers the risk of intraoperative bleeding, the use of thermal coagulation, and secures the clear visualization. We prefer to give bevacizumab 4 days before PPV. This interval allows a balance between neovascularization regression and reduce the risk of TRD progression. Standard dosing of bevacizumab 1.25 mg may be used, but even lower doses have been shown to be effective. Wide field viewing system also provide good visibility for vitrectomy. There are various options when we are using non-contact ReSight system. As you can see here, even without scleral depression, this system can provide enough peripheral view, and surgeons can easily correlate with the preoperative ultrawide field fundus images. Next issue is gauge selection. TRD repair has been reported with all currently available vitrectomy gauges from 23 to 27 gauges. The advantages of the 27 gauge system include a smaller diameter and more distal cutting port, allowing easier access between planes in complex ID repair. And also, bevel tip design of probe and high-speed cutting facilitated improved access to tissue plane. While bimanual surgery is still important in TRD, this recent advance in cutting probe enables surgeons to use vitrectomy probes only in TRD surgery. The smaller gauges may also have a smaller field of influence. With less vitreous traction, a potentially decreased risk of iatrogenic breaks. In TRD surgeries from PDR, Chen and others reported the post-operative results without significant difference in hypotony, visual improvement, and recurrent vitreous hemorrhage and reoperation rate between 25 and 27 gauge. This is my last slide. Three-dimensional heads-up display is getting more common. We use Zeiss TiVo 800 and conduct vitrectomy by watching the flat monitor with polarized glasses. Fast response and natural color, larger presentation of surgical fields help a lot, but the most important benefit is ergonomics. On your left side, you can see my unnatural curve of neck with bad wrinkles. But with the head-up display on your right side, the neck curve looks more natural. My chronic neck and back strain got reduced much thanks to this system. This is very useful, especially for a complex PDR surgery, which takes relatively longer time than others. Okay, my message today is very simple. In surgical consideration of diabetic retinopathy, ultra-wide field imaging is very useful in the preoperative planning, and also it enables easy post-operative follow-ups. May your diabetic surgery be always successful. Thank you for your listening and hope you enjoyed today.
Thank you for the very nice lecture, Dr. Lee. Very nice surgical videos as well. Okay, if the audience would like to put in more questions, do let us know. Just type them in and we will try to answer them. We had one question to ask about the fluorescein angiography and OCTA. I'm lucky, we have the OCTA system as well as the ultra wide field system, so I get the benefit of using both. I find that in terms of the macula, more and more, I don't really need to perform fluorescein angiography to assess the state of the macula, and I can use the OCTA. It saves the patient time as well as money and reduces the risk potentially associated with fluorescein. And you can actually repeat this quite easily, provided you have a good compliant patient who is able to fixate well for the duration of the image capture. Dr. Lee, would you agree with that?
Yes, sure. Fortunately, I also use sorry, OCT angiography, Heidelberg and Zeiss machine both. For macula, I just take OCT angiography only. Yeah, the reason is same as Dr. Lee Xuan said. So I'm focusing on the non-perfused area, increase the foveal avascular zone like that. So I tell the patient why your vision is not increasing, even your macula is flat. So yes, it's very helpful.
Dr. Raja Lakshmi, how often would you recommend using fluorescein angiography in the assessment of your patients with diabetic retinopathy?
Now, with the use of Octa and OCT, I think we are doing lesser amount of fundus fluorescent angiographies than what we were doing earlier. Of course, sometimes when where there's a very silent retina presentation, like how you showed a nice patient with asteroid hyalosis, those are the indications when we definitely fundus fluorescent angiography really comes to use, where the images may not be clear because due to asteroid hyalosis. Of course, we also have a lot of patients with nephropathy, that is a renal disease, where if the creatinine levels are high, we can't inject a fluorescent dye. So always a non-invasive technique like using OCT angiography or using OCT, I think the number of fundus fluorescent angiographies have definitely come down.
Thank you. We have a question for Dr. Lee. Would you like to comment on the view with the 3D scope?
Yeah, I have a wider, better view for using 3D microscope in normal surgery, but actually the detailed resolution is better in the conventional microscope still.
So would you peel a macula, a membrane on the macula with the 3D scope, or would you convert to the green lens of the Zeiss scope or a contact lens?
Yeah, I'm using both. I try to peel off the macular membrane using 3D microscope in usual time, but sometimes when the view is hazy or not optimal, I change to the contact lens system.
Okay, let's see. Okay, we also have some questions that the organizers have prepared. Can we have those questions up, please? Okay, so I think every clinic is equipped differently. What is probably on everybody's wish list to have a wide-angle viewing system in their facility. So what are you using currently, and are you quite happy with that? Is it a 45-degree standard fundus camera, or do you use one of the ultra-wide fields, whether it's the Optos system or maybe a Zeiss clearance system? Let's see what the spread would be. Because in SNEC, we have both the two Optos and we also have a Claris. So yes, so the 1/3 still using the standard 45-degree fundus camera. So I suppose you would still need to get the patients to look up, look down, look left, look right to try to capture as wide a field as possible. Okay. Do we have any other questions from the audience? Or amongst the panelists, do you have any questions for each other? Dr. Samuel, how many of your patients that you refer on actually require surgical intervention in terms of vitrectomy? And sometimes, sometimes the surgeons would tell you, I really need to operate. Can you get them medically optimized? And it's a challenge to get their blood pressures in a better state, get the sugars in a better state, to get them fit for surgery while trying to, save the macula and the retina as soon as possible.
Yes, there are many than we think, because we routinely get at least in our OPDs, at least in 50 of our patients, at least there are 2 or 3 patients definitely are coming on a daily basis for fitness with very poor metabolic control, needing surgery. Yes, and generally, since we have a good team here, so the ophthalmologists will take care of surgical referrals, but we not only from our center, but we also get from other centers too for metabolic control.
Okay, we have a comment. The lecture has shown that there is no alternative to a complete and thorough PRP in high-risk characteristics PDR. Targeted and partial laser and intravitreal injections do not help in the long term. Yeah, I think in all these patients, you need to look at them from a very complete perspective, medically as well as from the eye point of view. Dr. Raja Lakshmi, would you like to make some comments on this?
Yes, I think the non-perfusion, as long as there is non-perfusion, there's always more VEGF secretion and more risk of fresh new vascularization, etc. Nothing to a good pan-retinal photocoagulation to take care of high-risk PDRs. And I think that still remains the gold standard for managing proliferative diabetic retinopathy, even in the era of intravitreal injections. I think to reduce the non-perfusion and ischemic areas, hypoxic areas, I think good PRP is very useful.
So can I ask how many of you would actually recommend Protocol S, where in the you just give the intravitreal injections? Dr. Rajalakshmi and Dr. Lee, would you recommend that for PDR cases?
Early PDRs, I think, where there is just a neovascularization elsewhere alone, where there is 1 or 2 new vessels, when that time, those such patients possibly, they may just, patients who don't want to undergo a laser photocoagulation or nighttime driving issues because of a extensive PRP, where they may experience a glare, those are patients who may do well. But with high-risk PDRs, I think just intravitreal injections in isolation may not be very useful.
Yeah, I also prefer the pan-retinal photocoagulation extensively, but in young patients who need driving or like a kind of job problem, I restrict the photocoagulation to the outer side and using the anti-VEGF bi-monthly like that. So yeah.
But are you challenged by compliance in having the patients come in regularly for their repeat injections?
Sure,
because
sure.
a lot of them, by the time they develop PDR, would also need to see cardiologist and renal physician, and the legs need to be fitted with special shoes. They see, there is a challenge there as well.
Right, I agree. So after several months or several years, I finally do the photocoagulation to the major arcade area like that.
So either we give up, or sometimes it's the patients who give up because they can't keep coming back on a monthly or 2 monthly basis for their top-up injections. Sure. Yeah, I find that too. That's reality, even though you might say that, okay, we can keep on giving you the injections to preserve your peripheral vision, but or sometimes they just disappear because their kidneys have packed up and they've gone for dialysis and they don't appear for 6 months, and next thing you know, it's vitreous hemorrhage or tractional detachment. And you sometimes want to kick yourself because you said, if I had done a full PRP, maybe we could have actually avoided needing a vitrectomy at the end of the day.
Totally agree. Yes.
Do we have any other questions or any comment?
Yeah, there's one more question.
Yes, this is for Dr. Raja Lakshmi. Mobile retinal camera. which you can easily move from site to site and easy to use. Do you recommend?
Many, depends. Is it for screening or is it for use for actually examining patients who have sight-threatening retinopathy? For just screening patients, yes, the handheld simple devices are very useful. They are more cost-effective. You can take it for CAM screening, where even the remote rural areas you need sleek devices there. But once you have patients with established sight-threatening diabetic retinopathy changes, where you want to take a good look at the big picture, I think that is where I think ultra-wide field imaging really helps. For remote areas where you may not have a place where you can have a big device like a ultra-wide field image or a Diabetic Plus camera, such places a mobile device, handheld cameras are very useful, where you don't at least miss screening these patients, looking at least as the posterior pool.
Okay, I think we are going to be running out of time. We have one last question that we will try to answer now. Is there any future possibility of inclusion of OCTA in any device? We do have several pieces of equipment out there with an OCTA, from Zeiss to Topcon to Heidelberg, and even the Optos Nikon as well. I think the main limitation is actually cost for the OCTAs. And also you need to have good patients who are able to fixate well to acquire good images that you can repeatedly scan the patients with. Yeah, so that's the main issues with the OCTA. Okay, time has flown by. It's time for us to wrap up. Before we end, I would like to just let everybody know that there is a questionnaire at the end for feedback that Nikon-Optos would like, so that they can design future webinars that would suit your interests and your tastes, and hopefully they can arrange and organize more of these. It's been a wonderful evening. I would like to thank all the panelists for coming together and preparing everything. And for all our participants from all the various countries, I hope we have somehow helped enhance your understanding in managing your diabetic patients. I would like to thank Nikon and Optos for bringing us all together tonight. So have a very pleasant evening, and don't forget to fill up the brief questionnaire.
Thank you.
Thank you.
Thank you.
Ultra-wide-field imaging has come a long way since its inception. Over time, we've seen an improvement in our image quality, our ability to do fluorescent angiography, ICG, and now with the advent of the Silverstone, we're able to actually integrate swept source OCT in the far periphery as well as in the macula.
Unlike conventional fundus cameras, Optos ultra-wide-field devices capture high-resolution 200-degree views, showing 82% of the retina in less than half a second. Silverstone is a multimodality device capable of ultra-wide-field color, autofluorescence, FA, and ICG OptiMap imaging. Silverstone also includes swept source OCT technology, providing faster scanning and deeper tissue penetration. Silverstone offers multiple OCT scan options, including the 23mm extended line scan. With this, you can quickly assess and document wide areas of the retina without the time and discomfort of montage scans. Using Silverstone's unique OptiMap-guided OCT capability, you can easily capture OCT scans anywhere on the OptiMap image. This powerful combination of ultra-wide-field and swept-source OCT speeds clinic flow and positively impacts clinical decision-making.
We all know the OCT in this era is really important for the retina specialists and all ophthalmologists. We know the pathology of the retina And with the Silverstone, it's much better. Why? Because we have the challenging time to do the OCT on the peripheral retina.
Silverstone, with its wide-field OCT capabilities, has become one of my favorite imaging modality. It is my best friend in the clinic and the best weapon that I have in the battle against various vitreoretinal diseases, especially in the field of ocular oncology. I'm also an ocular oncologist, so I often find myself faced with the challenge of making tough decisions in the diagnosis and management of intraocular tumors. And I find the use of Silverstone extremely helpful in making correct diagnosis and surgical plans. I truly believe that Silverstone is going to be a game changer in the next decade, and I strongly recommend that you utilize Silverstone in your clinic.
With just a touch, you can obtain high-resolution swept source OCT scans anywhere on the Optomap. The process is quick, easy, and comfortable for both the patient and the operator.
And it opens up the possibilities for so many more patients without requiring as much of their patient cooperation. They don't have to turn their eyes as hard. We can get things much simpler, much quicker, and as part of a routine imaging for a patient, where before we would have to switch devices and spend a lot of time coaching them through and steering them, where now we can do it instantly, pretty much just during a normal Optos. If I see something in an Optomap, I just put a line on it or a volume scan and then send it off to the doctor. That way we don't have to have the patient come back, because I can do that on routine time. It doesn't take any longer than taking an extra picture.
Silverstone's groundbreaking technology provides deeper understanding of retinal pathology in the posterior pole and through the far periphery. Silverstone has been shown to improve clinical decision-making.
The Silverstone has now allowed us to examine pathologies in the periphery ranging from retinal tufts, degenerations, diabetes, retinal detachments, a whole host of pathologies, including choroidal tumors. Now being able to get deep information about these pathologies, determine whether there's vitreous traction, we're able to make much more informed decision and enhance our clinical examination and improve patient outcomes. The Silverstone has been relatively easy to use and integrate into our practice, and that as a multimodality device has really made a game-changing experience in our office.
World's only Optomap-guided swept source OCT facilitates detailed examination of the retina from vitreous through choroid. Silverstone, it is proven to impact your clinical decisions.